calling in, and for all of you that joined us down here in Olean, thanks for coming today. First, if you haven't had a chance to review the minutes, please take a look at them quickly. I know Karen sent them out for review earlier. And if there are no glaring issues, additions, or deletions, I'll take a motion to accept the minutes as presented.
It's Josh Lynch. I put my motion to accept.
Anyone want to second that?
On the 2 seconds.
Thank you. Moving on to the CMAC and SEMSCO report, there has not, I don't think, been a CMAC since our last meeting. The next CMAC is going to be next week, or in 2 weeks, excuse me, and there'll be some discussions about collaborative protocols and things which will come up later on our minutes here. So moving on, I am going to skip my report.
Joining the meeting.
Who just joined?
Oh.
So I'm going to skip my chairman's report for a little bit later as we talk about some of the other issues later on the list. Moving on to the Trauma Advisory Committee. Beth, are you on the line?
Yeah, but I don't have any reports.
Okay, very good. Lightning speed. The Nurse Advisory Committee. First of all, Bruce, I thank you for joining us. I know you're taking over as the Nurse Advisory Committee Chairman. Do you want to just kind of introduce yourself for the committee?
Yeah, no, Bruce Trepez from Mercy Hospital of Buffalo. Nurse Advisory Committee is something that's been out of commission for several years and trying to get back into the swing. We had some of our meetings we had moved on, got into a mission statement, trying to get some schedules set and everything else. Looking for scheduling a meeting. We'll be putting out probably the first week or the second week of June is going to be a meeting, and if there's now we're looking for the list of the active managers and or the emergency room directors are in the area of all the hospitals, because as they change, they rotate on who's the active people, so we can get a contact list. So if there's anybody available, or if they know if they're nurse managers, if the providers, the medical directors, could send them to my way or through this committee.
They're on our website.
Okay.
If you go to our website and under, I think it's resources or whatnot, but hospitals, as of the list, it should be right.
Okay.
It should be right.
Right.
They do change frequently, but they should be right. But it's only going to be for Wyoming, Erie.
Yeah.
So for the Big Lakes and Southwestern region, nothing for
That's,
won't be
yeah.
on it.
So for the Wyoming Erie region, if I could ask everybody to just, all the physicians or nurses on the line, to take a look at the REMAC website where those are posted, or is it on?
No, it's on the ubmdems.com.
Check that website, make sure that the nurse managers and ED directors are up to date, and for the Big Lakes and the Southwestern region, if we could have the physicians get an accurate, up-to-date list and email them to Karen, and she'll compile a list for you.
Thank you.
All right, very good.
Dr. Walters, this is Beth. I have a full list of everybody in the 8 counties.
All
I
right.
can send it to Bruce.
All right.
Perfect. Thank you, Beth.
Fantastic. Thanks. And actually, what I'll do, Beth, if you can send it to Karen also, and just so that we can send it out to all the docs and just make sure that everything's all up to date, unless you've got you're sure it's accurate and up to date.
Well, it's as accurate as people let me know, so I'll send it out.
All right, very good. Thank you. So this is Bruce's first meeting, and we appreciate having him here. And so he's kind of getting his feet wet, and anything we can do to help, just let us know, and we can chat afterwards.
Yeah, no, same way.
All right. Moving on to the program agency reports, we'll start with Lake Plains. I'm going to ask for the program agency reports, and we come talk by the microphone here for the benefit of those on the other end of the phone.
Oh, we had quite a few trainings over the couple months here. A few of the REMAC approvals, level of care changes, new medical director, I guess Dr. Aaron Farney is going to be coming on board. He's a big medical director from Livingston County. He's going to start taking over a couple other agencies in Orleans County. He's got quite a lot of credentials, shall we say. Another big thing is Big Lakes REMSCO. Several changes have occurred since the new chair with Wade, and we have a new mailing address. Everything is going to be actually coming through the program agency now. Gets scanned, gets uploaded, so things don't get lost, shall we say, because we're trying to compile all the files together, and we noticed that there were some pads that weren't even opened. So everything's going to be coming through Lake Plains now. There's a new website for the REMSCO, which is biglakesremsco.org, and now the REMSCOs have emails, so that way if you have to contact them, it's not personal emails, it's strictly chair@biglakes.remsco.org. And the next Big Lakes meeting is June 8th. I guess there was an incidence of an EMT imposter. Just a strong reminder to contact program agency when you have a new EMT, and you can use the New York State Healthcare or Health Commerce system to check EMT numbers. Would have been prevented if they would have contacted us or the state. Starting the new New York State instructor exams is this month, education based. November 15th, Lee Burns going to have a State of EMS meeting at Niagara County. More details to announce later.
What's the date?
November 15th. And then September 17th, we're going to have a certified instructor update. And more details about. That's pretty much about it.
All right, before you step away real quick, so Dr. Farney comes from the Millrims area. I know he'll come up in these new medical director approvals later. He's an EMS physician, fellowship trained, and in good standing with the Millrims, already online as a medical director there. So, and number two, can you explain this EMS imposter situation?
Well, I can't go into too much details, but I guess there was someone that knew the lingo, fire service and EMS, and I guess he provided some care to some individuals without giving an active card.
When responding as what part of the fire department?
Yes.
Okay.
He was in several, I don't know if Ed's able to.
Yeah, we did send him over to the state police. He had a nice visit with them, and he was arrested on multiple felonies, and he did falsify PCRs and falsify that he was certified as an EMT. So that situation was an interesting situation because the guy had come up through the ranks in the fire department, took an EMT test, but he failed it. Didn't let anybody know he failed. The agency's primary agency did not verify that he actually received a card. Then he sort of went to the military, came back rather quickly, and they just sort of let him keep going. He didn't produce a card. So it all kind of came together when he joined another department, and he never produced his card, and then it started, the chain rolling. But I think he had about 17 felonies. I'm sure it'll be pled down, but he's not certified, so we really don't have jurisdiction over him. But we did send him to the state police. So.
This happens about once every 5 years.
Yeah.
Well, I think it's another reason for PPAs.
Yeah, very, very strong. And there was another gentleman too. We were not able to get any real facts on that, but so there was some other reports that there was another one running around in Niagara County that was previously certified and was kind of showing up at scenes. But we referred that to the town of Niagara Police Department. We haven't been able to get any further detail. I don't know if it was just a one-time incident or what have you, but yeah, it's very unfortunate. So, and we did with those agencies that worked with Lake Plains. There was 3 agencies that were involved, and some of them, one of the things that I would emphasize is that the guy was primarily in one agency, but in the rural areas they're mutual aiding, so they're all being dispatched. So this guy was jumping on other ambulances as an EMT from that department. So he really wasn't a member of the other department, but verification of the certification is critical. So.
Absolutely. Thank you.
All right.
All right. Moving on to STEMS. For those of you that don't know, Jen Budai, who was the EMS coordinator for STEMS, has since moved on, and the new person taking over that position is Abby Kane, who is going to give us the STEMS report today.
Thanks.
Welcome.
Thanks. Hi, everyone. So at STEMS, we had our 10th annual spring training, April 15th and 16th. We had over 225 providers from Western New York and Northern PA. I think it went really well. It was about pediatric emergencies. Another thing we had this past month was on April 26th, Beth Moses did an orthopedic emergency presentation, which was distance learning through Olean, General, Jones, and All-Star. some things we have coming up is a provider skill fair at All-Star North in Dunkirk on May 14th from 10 to 2. We will also be doing a Friends and Family CPR for CPR Day on May 25th at 6 p.m. at the CAC, the Child Advocacy Center here in Olean, Jones, and All-Star. That's for Friends and Family compression only. And then on June 28th, we have a Less is More training that Karen Hill from our CAC will be presenting on. We also have 12 agencies in the process of adopting EPCRs and 37 that are live. And only one agency we had late PCR we're still missing is Richburg from March. That's about all we have going on right now other than our county meetings and obviously SHREM's meeting, which is June 1st.
Very good. Any questions for STEMS? All right. And then UBMD, Scott?
We also completed our conference last month in April. It was very well attended. It was our strongest attendance at any of our previous conferences. Working toward next year, and we also have a fall one-day symposium that we're going to be doing on November 5th, and we'll be announcing more details on that in the coming weeks. Lots of activities that are going on next week, being EMS week. As we become aware of them, if anybody could really just let us know, primarily for the Wyoming area region, but just let us know activities that might be going on at hospitals. I just kind of want to do one blast out to the EMS community through our email listserv to let people know what's going on. So any of the hospital contacts, if you could just let us know, that would be appreciated so we could get the information out.
Scott, do you have us down for the 18th for Colitis?
I don't have any colitis information yet.
Yeah, it's the 18th from 11 to 7 at all sites.
Okay.
For nighttime, food will be provided, box lunches after 7 p.m., but during that time from 11 to 7, that's going to be all, grilled food and everything like that.
Okay, great, great. Probably a couple of things here. All the BLSFR services statewide are going through an update. This is going to be extremely important. It's kind of like a once every 5-year deal for the BLSFRs. It's not formalized, it's not in regulation anywhere, it just is really what the Bureau is trying to do to make sure that the records are up to date and that services that are participating in the CMU-based research program and have their state code to be eligible to get the free EMT training, they want to make sure that they're participating and routinely involved in the EMS system so that they can get the entitlements, so to speak, that come with having a state code. So all of the BLSFR services were sent a packet from the central office in Albany from the Bureau asking for updated information, which this will impact the docs because a part of that is the medical director verification form. And so if you have any BLSFR services, they're going to be reaching out to you to get that information. I guess the one thing that we're just kind of asking is that as these services, as you become aware of your services that are doing these updates, make sure that the program agency receives a completed packet of that whole BLSFR update packet. A lot of times we can cut things off at the pass. The central office needs something, they don't have it, didn't receive it, lost it, whatever the case may be. They reach out to the program agencies first for this information, and we can usually just get it to them and then not have to get the agency involved and figure out who the EMS officer is this week to try to get the packet that was completed 2 years ago. So anything that people could do with that would be very helpful to everyone. Bunch of trainings coming up. It's listed in the report, and we have a couple of action items. The last thing I want to report on is we are now in beta testing with the web-based provider portal. And this is the system that we're going to be utilizing for registering providers with agencies. It's also the system that we're going to be using to manage everybody's credentials. It's kind of a bad time to be doing this because it's going to fall right on credentialing, but it's a good thing too. So over really the next 4 months, we are going to be training all of the services in Erie and Wyoming County on this web-based system, and we will be transitioning 100% over to this. I can say that I'm being very aggressive and optimistic to say that we're going to be live with everybody by September 1st. That's our goal. Realistically, it'll probably be by January 1st. But we have to figure out how we're going to tackle credentialing for the reporting deadlines. I don't have a concrete answer on that right now. But we're going to be between paper and electronic for this period that ends June 30th. But we're going to have to figure something out on that. But it's exciting. The medical directors will also have logins. You will be able to see things that are going on within their services, who your providers are. It's a lot of transparency. As communications are sent to services, the medical directors will be aware of it. If a provider is placed on a restriction, the medical director also gets notified through the system. It's very comprehensive. So more details to follow, and we'll gladly show it to anybody who wants to see it. So
I think that's a great thing. I think that there's obviously going to take a little time to get it up and running, and especially with PPAs this year, but being able to track in real time and notify people of delinquencies, deficiencies, out-of-date information, especially for the medical directors to be involved, I think is fantastic.
Yep. That's it.
Good. Thanks.
Thanks.
Any questions for Scott? No. All right, moving on. Subcommittee reports, the ALS protocols we'll talk about when we get to the collaborative protocol updates under old business. And for the QI committee, Dr. Lundberg is not here. He worked overnight last night. And I will just say that the QI committee is reviewing a case. It's actually an appeal from a provider who was taken offline as a provider restriction that they're actively reviewing with a committee. Some of you know about that, are involved in the process. Other than that, we'll move on to old business, and starting with the MPDS dispatch response plans. Dr. Clemency, if you're on the line, do you want to tackle that?
Sure. So in an Excel file that was sent out to the members yesterday, we met probably 2 months ago to go through the version 13 codes. Again, as it says in the file, this is just one possible recommendation, and individual agencies or individual dispatch centers are free to modify this, set it on hold, or totally disregard it and do their own thing as they see fit. One of the important changes that was made this time around was that in the old system, there were times where response plans did not always go from largest response plan to smallest response plan in order of procurement. You might have a situation where the computer was trying to give a lower response plan to a patient based on the order of determinants. We fixed that. The way we fixed it was, if there is a paramedic determinant at a certain level, say Charlie 2, there can't be a lower determinant response plan above that. So if Charlie 2 is a paramedic response plan and the group discussed making Charlie 1 an AUT response plan, it was automatically made a paramedic response plan, and everything would go in the right order. There was also a question about one of the things in the protocol is a little different than the recommendations made by burn centers. There are some places where MPDS varies from other recommendations, whether it be the HA guidelines or burn criteria or trauma criteria. We are not able to change those criteria. And I would only just point out that those criteria are based on what response to send and are not intended to be what hospital patients should go to. So it's a different set of criteria altogether.
Hey, Brian, not to interrupt you, but just
Are there any questions?
Brian, just to that point about the burn criteria, I think in the dispatch protocols, I think it's 18% versus 20% listed other places. And I think the reason is because with rule of nines, it's easier to estimate over the phone for a dispatcher than it is to try and figure out is it 18 or 20%. I think if you're using that, I think that's why the 18% number was chosen nationally. So.
And just in general, those are things that unfortunately the end user has no ability to modify anyway. All the end user can do is create response plans. They can't modify the protocol itself.
Overall, how many changes were there compared to the out-of-the-box, quote-unquote, MPDS system?
So the biggest change, so if you look at the out-of-the-box MPDS, that would make paramedic calls Delta and Charlie, and basic calls Bravo and Alpha. Probably the most important change is some of the Charlie and Delta calls were made AEMT calls. And some of the, I believe some of the other cards are made Bravo. So if you look at it, places where there's a Bravo or AEMT determinant on the Charlie or Delta level, that would be a difference. I don't have an exact number of cases on the top of my head.
I know we did this in committee, and this is something that the REMAC has kind of traditionally done every time there was a new version and made available as a resource guide, not a mandate in that. Is this something that we need to vote on to approve, or because it's just a suggestion, take it or leave it, or modify as you will? Is there anything we need, any action we need to take on this, Brian?
It was traditionally voted on at the REMAC. I think whatever the REMAC decides is fine either way. I guess you guys could vote on voting on it, or not, or whatever you're doing.
I think we're going to need a meeting to meet about whether or not we should vote on it.
As long as there's food at that meeting, I'm in favor of that.
I guess I have some mixed feelings about whether or not we need to vote on it, and I'll just kind of informally poll the crowd and those on the phone. Since not every dispatch or PSAP center uses MPDS, since a lot of them still use APCO, we don't formally, as a REMAC, recognize or approve either system, nor do we officially approve the dispatch protocols. Those are to be done by the dispatch center and their medical director. So I don't know that this is really something that we need to vote on. I think it's a helpful resource, and I think it's a guide for PSAPs and medical directors who don't have all the resources to go through all these things. But unless anyone feels strongly about us needing to take a vote to endorse this, I don't know that that's necessary.
I think the only thing I would offer is that if you're making this available as a regional resource, and you're saying that it's kind of what the REMAC as the chief regional medical authority is providing as a resource, I think you probably should at least just formally adopt it, rather than, and I think it just gives better protection to the PSAPs that might utilize it. No, I don't see anybody picking this thing apart, but
I'm not opposed to that. Anybody on the phone have a opinion one way or the other?
This is Sarah. I prefer that we do vote on it, or at least we do it from the REMAC. Just so there's I can have a little backup for when we have that.
Okay, I'm fine with that. Sarah, are you phrasing that in the form of a motion?
Sure.
Thank you. Is there a second to Sarah's motion to adopt the MPDS dispatch response plan resource?
I'll second Dr. Conley's motion.
All right, I will take a vote unless there's any other comments or discussion. I'm going to vote. All in favor?
Aye.
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 Any opposed? Any abstentions? And the motion shall carry. Thank you, Brian. Next on the agenda is the collaborative protocol update. As you know, we have voted in the, we've been talking about collaborative protocols for a couple of years now. The newest or latest draft of the collaborative protocols has been circulated, and it will be going to the CMAC for a vote in 2 weeks. We at the REMAC had voted previously to adopt the collaborative protocols and have signed the MOU. And there is the final draft of the protocols is now out for circulation and comment. The Bureau of EMS, in contrast to previous discussions and rules, is now allowing the program agencies and the regional councils to distribute to their hospitals electronically. They do not have to be formally mailed in paper or certified mail anymore. So there will be a letter coming out, and those protocols can be disseminated. There is, for anybody who has any comments or feedback, there is a link in the letter or the email that will take you to a SurveyMonkey, where you can actually put in your comments, rationale, any supporting evidence, and then that gets tracked by the collaborative protocol group. I ask that you send any feedback through that mechanism, not to me or Karen or anyone else at the REMAC, because this actually, when you send it through the SurveyMonkey, it actually ensures that the collaborative group looks at it collectively. This is not a REMAC thing, this is actually a group of REMACs who are doing this in conjunction with one another. That being said, I will just make a couple of general comments. Some of you have seen this and had some feedback, and there are going to be some substantial changes to our protocols. In certain instances, there are things drugs that will be removed that have always been in our protocols. And this is not because we are trying to limit people's scope of practice or ability to give medicines or anything like that. But as times change, we realize that some things that we've done just aren't necessary or don't make a difference or don't need to be done, even though it may be good medicine, it may not need to be done in the field. So you'll see some changes there. There will also be some changes, formulary changes, meaning things like moving from verapamil to cardizem, things that are really just best practice drug changes and things that are evolving with the standard of care, and things that we just have to move and adapt with, I think. But I think they all are in the best interest of patient care and really keeping up with the standard of care across the country. That being said, some of the controlled substances will be changed. There'll be a lot more push for Versed and for fentanyl, and that goes along not just with what's being done across the state, but also nationally what agencies are doing, and good data to support those medications. And my last general comment is regarding level of care for CCs and AEMTs. There was a group put together across the state, which a lot of our AEMT providers participated in reviewing protocols and giving feedback to the collaborative group. The version, this draft version that you'll look at, has not yet incorporated any of those potential changes or suggestions yet. They're still being reviewed and are going to be discussed at a in-person meeting of the collaborative group at the CMAC in 2 weeks. So for those of you that participated in that, don't get concerned if some of those AEMT suggestions haven't made it to the draft yet. And there are some changes in the what CCs can do on standing order versus what they've been able to do for a long time in this region. That's trying to adopt their scope of practice as it was intended across the state, and also to recognize that there is a difference between CCs and paramedics, both in the amount of class time, the amount of clinical time, the education, and things like that. Things that are listed at the paramedic level, not at the CC level, still are medical control options if they're in your scope of practice that you can call for, but some things have been removed. And the two big things that keep coming up are with pediatric patients, IVs, and intubation and airways. And the reason for that is that most of our providers, including paramedics, have very limited experience and practice in putting in pediatric IVs or doing pediatric intubation. It's just not something, thankfully, that we see and have to do a lot in the field. So there's just not a lot, it's a very low frequency skill, and the discussion was whether or not our providers are all proficient to do that. There's also very good evidence that with pediatric patients, whether they're medical calls or trauma calls, that basic airways and bagging a pediatric patient has the same outcomes as pediatric intubation in the field, and pediatric intubation has a very high rate of missed tube placement, dislodged tube, and unrecognized dislodgement of the tube. So you'll see those changes. And lastly, when we talk about pediatric patients, we don't put in the quote-unquote prophylactic IV or IV just because, like we sometimes do in adults. And so some of those skills, you'll see them either removed to a different level of care or kind of placed as a medical control option or de-emphasized for all of those reasons. So again, we've already voted to adopt the collaborative protocols. We will circulate the protocols for review and for comment during the comment period. But as we're looking at our comments, giving feedback and reviewing them, I just want to make sure that we focus on looking at things that are, maybe errors that are in there, things that could or should legitimately be put at a different level of care, or things that may have been oversights. But again, we're not voting on or looking at these as should or should we not approve them or join the collaborative efforts. We've already voted on that. That being said, if there's any questions or comments about the collaboratives, I'll entertain them now.
Brian?
Yes.
So we had a discussion a few weeks ago about cardizem, and you had mentioned that there is now a reconstituted form, but I can't seem to find it anywhere. And I got this question from a couple of different agencies. The only reconstitute that I can seem to find is for like making a drip. It's like 100 milligram reconstitute. Are you aware of a single dose reconstitute that our providers will be able to use?
There is. It's being used in agencies across the state. I think actually a couple agencies in the region use it, but I could not give you specifics on it, so I will find out and get back to you, but that is available.
Awesome.
Yep.
Awesome.
And avoids refrigeration issues.
For people all along, so
Yep.
you know, I think it's great if we can find it.
Very good. Any other specific comments or concerns regarding the collaborative protocols? No. Then we will circulate a REMAC letter, the actual draft of the protocols, in the next day, and then ask that the program agencies and regional councils push them out to all the hospitals as usual for comment. Very
Mike,
good.
do you have any timeline in mind for us for the cover protocol?
Yeah, so the collaborative protocols, that's a good question, thank you. Will be presented and I assume will be approved at the next CMAC in 2 weeks. That is the approval date for the protocols. None of the regions are going live with them quite yet, and there's a couple of reasons for that. One, even though these are collaborative protocols, they will be implemented at different times in different regions, different REMACs, just based on resources, number of providers, educational rollouts, and things of that nature. The first step is to get these approved at the CMAC. At that point, then there is a, as you know, the REMO in our region has an app, and there's been discussion about protocol apps and things like that. The protocols had to be completely finalized and approved by the CMAC before they could be go to the app company and have the app start to be developed. Once there's some more feedback on the time frame for that, then I think we can look at when we're going to actually implement them and what our time frame will be. There also has been discussion about how we roll them out educationally. Even though these are collaborative protocols and started at the Albany region and the REMO, and some of the other ones have already gotten on board, these are actually a very big overhaul even for those regions. There's a lot of big changes in that there really reflect the best of all the protocols, I think, across the state. So there's been discussion on whether there should be individual education done by every REMAC, or whether it should be across the board, everybody doing one type of educational webinar or podcast or something like that. As it stands, I think one of the regions had offered to host a webinar or educational podcast that you could log into and do the update online for, and also giving, not just coming up with one for everybody, for all the regions that are joining the collaborative group, but also have the ability for individual regions such as ours, if we said, hey, there are certain things that our providers haven't done before that we think we want to emphasize a little more, have the option for them to host something specific for our providers. So until those things have been worked out and we have a time frame and actual mechanism for how we're going to do that, we don't have a go live date for our REMAC yet, and I think that's probably something we should discuss after the discussions at the CMAC in 2 weeks. When we come back at our next REMAC meeting, then I think we should look at time frames and when we actually want to implement and go live at that point. Any other suggestions or concerns regarding that? Last thing I will say, some people did bring up, there are some things that are in our REMAC protocols that are not in the collaborative protocols. Some things, there's a lot of discussion on what should be regional variations, regional options, and things like that. So those operational type protocols will remain, they'll still be done at the regional level. They won't be in the collaboratives. That includes things like helicopter utilization policies, interfacility transports, and things of that nature. The collaboratives really are focusing more on the medicine and best medicine practices as opposed to the differences in operations between the regions, and they take that into effect, or into account. Any other questions on that? No? All right. Next under old business is the PPA credentialing reminder. Reminder that PPAs for all providers are due by, someone correct me if I'm wrong here, June 30th? All right. This is now, I don't know how many years in a row we've been doing this. I think there's still some pushback for some agencies. Last year there were some big agencies that did not comply and were almost taken offline because of it. And we have made, the medical directors and the REMAC have made the decision in the past and continue to enforce this policy that any agency that is not in compliance will be taken offline receive notification as outlined in the PPA policy. Scott, do you have anything else you want to say about that? No. Dr. Clemency, Dr. Lynch, or anyone else on the phone want to say anything else about PPAs?
I don't think so.
Our anxieties.
So I will just
I agree
ask,
with Dr. Lynch.
you agree with Dr. Lynch? What, silence?
Yes, thank you. Do your PPAs.
Yes. I would just ask that the program
There's not
agencies,
much to add.
just the program agencies, if you can work with the medical directors and agencies that have not gotten in their PPAs or look like they're about to be delinquent, so we can be proactive about reaching out and really trying to get them in and done on time. Next, not listed under old business, which I think is an omission, but was discussed at the last meeting, is that the state has approved a BLS for 12 lead as an optional skill for the basic level. There is a state policy on this. We had some discussions in the past regarding how to roll this out, and I think that it's a little bit, I think it's a little different in different parts of our region, being as diverse as we are, whether we're in rural areas and there's one hospital that everybody transports to versus being in the more urban areas. As this comes on, goes on longer and longer, I think we'll see more agencies want to do 12 leads at the BLS level, especially agencies that maybe have dropped from the AMT level or from the CC level in the past due to some of the other requirements. Again, it's optional, it's not a requirement. I don't know if anyone is aware of any agencies that are really looking to do this right away. But I think before we have as we start to get agencies who want to roll this out, we need to have a policy for the acquisition and transmission and how those EKGs are transmitted, where they go, who reviews them, and things like that. I don't know if that's something we want to discuss here right now, but I would suggest that if any of the medical directors are interested, or providers from representing agencies or the regional councils, that maybe we try and set up a subcommittee to look at this as to how the best way is to implement this going forward.
Yeah, Brian, I've looked at the draft and given this some thought. The biggest issue is whether or not we're going to transmit 100% of all leads, or whether we're going to use the computer interpretation to siphon off which ones to send or not. There is a discussion about 100% review, but it doesn't make it very clear that 100% review needs to be at the time of the call. Perhaps could be a quality assurance piece. So I'm happy to work with a committee if people are interested in doing this between now and the next meeting, to have a drafting part of the REMAC.
Okay, I appreciate that. I think it's different. I think in some of the rural areas here, like in the area right here around Olean, all the EKGs typically get transmitted and reviewed by the ER physician, at least the patient's being transported here. So I think that is going to be different depending on where we are regionally and hospitals and things like that. But I think we should have some of these discussions and hash some of these things out. Brian, I'll put you and myself on that committee. Is anybody else interested right now off the bat? Andy, Scott? Taking notes? All right. Anyone else who maybe is interested and doesn't want to speak up, then you can email Karen or myself, and we'll add you to the list and try to at least put together a meeting or a conference call to discuss some of these things. Abby's on the list too. Mickey nominated her. All right. All right, very good. This is like a Dr. Clemency speed type meeting at this pace right now. Nobody mess it up, please. Moving on to new business. The next REMAC will be, I'm sorry, not the next one. The September meeting will be in the Big Lakes region. Do we have a location yet, or are we still working that out? Maybe?
That's a good question.
All right, we're still working that out then. Very good. I would like to make my monthly plea for vice chair nominations. If anyone would like to be the vice chair of the REMAC to take over as the REMAC chair in a few months, that would be greatly appreciated. Dr. Lynch, thank you for your interest and nomination. All in favor?
I decline. I respectfully decline for the second meeting in a row.
Just making sure you didn't fall asleep. Anybody else?
I agree with Dr. Lynch. a collaboration we have, Dr. Clemente.
Yeah, that's fantastic. Thanks, guys. Keep that in mind. Think about it. Discuss it in your meetings, and please, somebody volunteer. Moving on, Brian, do you want to also talk about the UR Siren and the University of Rochester program?
Yeah. So the University of Buffalo actually has two requests for Siren support. Siren is a large emergency medicine / pre-hospital care research grant system. Some people are referring to it as the next thing that's going to replace the ROC research programs, if you know what those are. What's happening now is it's going to be a hub and spoke model, and different hospitals and academic centers are jockeying to become the hub location that will get the sponsorship money from the Siren Network. The University of Rochester approached University of Buffalo as well as Dr. Walters to support their application. So they're asking for a letter of support from the WREMAC to say that if Rochester gets it, that we would support their endeavors. Separately, SUNY Downstate, which is in the city, has also asked us to do the same thing, which is for the University of Buffalo to support their application and for the WREMAC, if it's willing to, also support their application. It seems very unlikely that both will get it, so there's not a big downside with supporting both programs. That's what Buffalo is going to do. It is up to the WREMAC whether the WREMAC wants to support both applications or only support one of them. Jeremy Cushman has really gone out of his way to reach out to Dr. Walters and I to get the WREMAC support. Downstate has not extended itself in the same way as of yet. I'm not, we're working with them, but they have not reached out to the WREMAC directly.
So, Brian,
I think we're all in agreement that the WREMAC could and will hopefully support the Rochester program. So the question for the WREMAC is whether they want to also support the downstate application or not.
I guess, Brian, I guess I have a couple questions. One, what type of things is this program actually going to be doing, or how is it going to impact us as a WREMAC and our EMS providers? Can you just talk to that a little more?
Yeah. So the first obvious question is, does either one get it, right? If either Rochester or downstate get it, then UB would be a spoke site for them, so that they would present us with research projects and ask us whether we want to be on board with those or not. And we have no sample research projects yet. So nothing would be forced on any agency. What would have to happen is if there's a pre-hospital study that the individual agencies would agree to participate or not. And theoretically, the region itself could prohibit any research project I think is dangerous. But I would anticipate most of this would actually be done by the larger agencies anyway.
Okay. So I think that, one, it makes good sense for us to want to be involved in promoting research in that as a WREMAC and as a region in that. Obviously, this doesn't bind individual agencies or providers to participate, so I don't think there's a downside to that. And I guess the only other point that I have before we talk about voting is that University of Rochester has gone out of their way, like Dr. Clemente mentioned, and at least contacted us, asked for us for support, and drafted letters of support for us in that. We haven't actually gotten any official correspondence, from SUNY Downstate, and so until they officially ask us as a WREMAC to support them, I don't think that we can vote to do so. I think that's putting the cart before the horse, although I'm not opposed to that.
Well, so Brian, I would say that I'm asking on behalf of them.
Okay.
You can take from that whatever you choose to take from that, but
okay.
Yeah, I'm asking on behalf of both agencies.
Okay, and the University of Buffalo is supporting both groups?
We are, and that's correct. Our chairman, Dr. McCormick, has stuck with both of them, and he's made the decision that the University of Buffalo is going to support both applications. It's unlikely that they will both get it. It's possible that neither will get it.
Okay. All right. Then I guess I'll open it up for some discussion to the group about how they feel about support. If anybody is, number one, opposed to supporting either program, and how we feel about supporting both. My personal opinion being, I don't see a downside. I think it's good for the region, it's good for education, it's good for research, and I would not be opposed to it. But anyone else have any other feedback or suggestions? No one?
I think everybody worked last night or something. I
All
don't know.
right.
It's never like this.
All right. Then I guess I will, Dr. Clemency, do you want to make a motion then?
Yes, I make a motion that the chairman writes a letter in support of both applications.
Okay. And just to be clear, that I think that it is that we're voting that the REMAC would support both applications, and the University of Rochester actually has a letter of support that gets signed not just by the REMAC chair, but also by the regional councils as well.
So specifically that for Rochester, I'll sign one in conjunction with all the regional councils. For downstate, he'll just sign one under his own name.
Anyone want to, any second for that motion?
Come on, Mitch.
Wait, now Josh is quiet. We're going to bring up the REMAC vice chair nomination. Hang on one second.
No, I'm still here. Don't worry.
All right. Is there a second for the motion?
Joseph, seconding.
All right. Any discussion on the motion or comments, concerns before we vote? Hearing none, all in favor of the REMAC endorsing and supporting both the Downstate and the University of Rochester siren projects? Aye.
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 Any opposed? Any abstentions? All right, the motion carries. We'll draft a letter and we'll have the regional council chairs sign and approve as well. Next on the agenda, moving on, we've already talked about the Nurse Advisory Committee and Bruce taking over. Thank you. The next item is a Solumedrol shortage. Many of you have been aware and raised some concerns about Solumedrol, which is in our protocols, being on national shortage, being the latest of the national shortages. Our hospitals also are having a hard time getting that and are switching to substituting dexamethasone or Decadron. Interestingly, this did come up in the collaborative discussions about which steroid to use, and if you read the draft of the collaborative protocols, they actually do go to, do not include Solumedrol, but do include Decadron or dexamethasone, and the reason being that dexamethasone can be given both to adults and pediatric patients, but can be given PO, IV, or IM, and is also happens to be available where Solumedrol is not right now. My suggestion, and that from those that have contacted me regarding this, is that we draft a policy of medication shortage, allowing dexamethasone to be used in lieu of Solumedrol, but to be used in the dosages that are in the current draft of the collaborative protocols going around. I guess there's a little bit of a discussion about whether the REMAC can, and maybe Ed, you can speak to this a little bit, whether the REMAC can actually do this themselves or whether this needs to go to the CMAC for approval. It is not actually in the state medication shortage policy. There are some alternative drugs for paralytics and other controlled substances, but there is not one. Steroids are not specifically listed in there. We did reach out to the Bureau of EMS, and they were forwarding it on to the appropriate tag for emergency approval, and if approved, we would be able to then adopt that in either between now and the CMAC or after the CMAC. I guess my only concern with waiting on that is that we now have many agencies that have already run out of salmeterol and
Exhausted.
don't currently have any steroids. So, I mean, I'll just pull the phone and pull the room. Has anybody, how many of you are seeing shortages in salmeterol right now? I'm seeing,
sir.
yeah, I'm seeing a lot of nods around the room. I guess, Ed, I will ask you, I reached out to Andy again this morning, but haven't heard back on the status of that. About what we do in the meantime, if we have to wait 2 weeks for the CMAC, or we have to wait for a tag approval, or if this is something that we can just adopt and implement.
You know, I don't have the authority to say that it's acceptable if it's not in the, you know, in the formulary, but it is somewhat of an emergency. I can certainly make a phone call to the bureau director and find out what her take is. You know, if there's a way that the REMAC can, and I'll step out and do that now if you'd like.
I don't know if it has to be right at this moment,
Or if I could follow up with you within, you know,
Yeah.
24 hours or something like that. And I could, you know, I could certainly call Andy to see if there's been any progress on it, but.
yeah, my concern
would
is
you-
just waiting another couple of weeks. I mean, we've
Yeah.
already taken the liberty, and some of you have seen it, of drafting a memo
Right.
with the approved dosages as in the collaborative
Yeah.
protocol. I think that there's no doubt these will be adopted in 2
Yeah.
weeks anyways.
And this was not included in the previous approvals for alternative medications based on shortages.
Because there wasn't a shortage.
As you guys said, there was no shortage, so,
Right.
you know, I guess probably, you know, we should, I mean, you can't forecast them, but we know they're
Right.
gonna occur. So I guess I could say is I'll try to get you an answer within 48 hours, if that's, or 2 business days, something to that effect. Is that
Scott?
reasonable?
Yeah,
Or-
no,
yeah.
that's, Scott, do you have an opinion as the
I-
self-appointed parliamentarian?
Did you like that? Yeah, you know, we should not let bureaucracy get in the way of good medicine. But I guess the only thing, you know, if it were me personally, I'd say, yeah, go for it. But you know, we have to advocate that we follow the appropriate channels. You know, same boat that you're in. I guess the only thing, you know, it's the typical issue of the overused word liability, but that's really what this all comes down to. We've had similar issues come up, and Dr. Young has just spoken during his tenure as the REMAC chairman, and then of course wearing his hat as, you know, the associate commissioner. Just says you just can't do these things because of the you know, the position and the liability that it places on the docs, but the agencies, the providers too, who would be following these protocols that aren't approved. So I think it's going to depend on what the answer is that's given from the Bureau, and I think whether we like the answer or not, or whether we think it's even in the best interest of the patients, I think we kind of have to follow what they're telling us to do. Because as this organization, you're following the state statutes, and you're really a committee of the state in your role here, so you kind of have to follow what they're giving us guidance.
Right. So I'm going to ask the first question to the physicians on the line. Is there anyone who has any disagreements with allowing dexamethasone as an acceptable alternative to salmeterol? Any concerns or issues with that?
No.
Anyone?
No.
All right. Anyone not support dexamethasone? Okay. So I guess my next suggestion, and Brian, I know you and I have talked about this, and Josh, please feel free to weigh in, or anyone else. We'll try to get some clarification out from the state, and as soon as the state can give us some guidance, if we get some type of emergency allowance to do this, I think that we should then go forth with you know, as a REMAC promoting dexamethasone as the alternative, because that's what we're going to be going to in the future in the protocols anyways. In the meantime, It is still a corticosteroid. It is still a medication that our paramedics and our CCs are educated in using. It is in their scope of practice. And I think that as the kind of get around in the next few days or the next couple weeks for agencies that have run out or have begun to stock dexamethasone, I think that we can default to making a medical control option until that point. And I will also circulate the draft. I'll have Karen send out a draft letter once we get some word from the state that has the actual specific dosages for dexamethasone for the adults and pediatrics and the different protocols. But I guess what I would ask for this time would be a motion from the WREMAC to endorse using dexamethasone as an alternative to solumedrol, as discussed.
This is Josette. I'll make that motion. You verbalized it.
Is there a second?
I'll second it, Sarah.
Thank you, Sarah. Any other discussion about dexamethasone? All right, all in favor?
Aye.
Aye.
Anyone else want to vote there?
Aye.
Thank you.
Sorry.
Any opposed?
Well, yes, that's just- that's all.
Any abstentions? It must be a server issue with a delay or something,
Yeah,
or
right.
FaceTime. So then, for the moment, any agencies that have dexamethasone, I'll leave it up to the individual medical directors to educate them on utilizing it as a medical control option for right now. Once we get some word back and clarification from the Bureau, then we will put out a formal memo. But in the meantime, I will have Karen circulate a draft letter with the appropriate dosages from the current draft of the collaborative protocols out to all the WREMAC members and to share with the physicians. All right.
And you basically have confirmed that it's not been approved in any other region
I did,
previously?
looking at it, I see, when I looked across, and I'll be honest, I looked at Milren's, I looked at Central New York, and I looked at the Remo, and they all have solumedrol in their protocols
not-
right now. I didn't
yeah,
see
gotcha,
dexamethasone
okay.
currently approved somewhere, so.
Okay, thank you. I
Although,
mean, that would be the answer.
although in 2 weeks, it's
Boom.
gonna, that's gonna be the change
It'll
when
be
the
changed,
collaboratives
yeah.
get adopted,
Yeah.
so, but in that 2-week period, it'd be
I
nice
understand.
to roll something out anyways. Moving on then, as we come down to the end, I will, on the agenda that Karen sent out, there is some medical director approval changes, pad notifications, level of care change, naloxone, check and inject approvals, CPAP approval, glucometry approval, and just a quick point, before I ask for a motion and a vote to accept all those as a group, I just want to say we have discussed in the past that asking the program agencies to check before bring any of these to the WREMAC, that they do their due diligence in looking at agencies, making sure that there are no delinquent PCRs, PPAs, or other administrative issues. I will say that I had an agency approach me recently who was trying to tell me they were not going to do their PPAs, but at the same time asked me to sign for them to do check and inject, and you can probably understand how that conversation went. Needless to say, they may be offline and they're not going to be doing check and inject. But that being said, I will now get off my soapbox and entertain a motion to accept all these approvals and changes as a group. Is there a motion?
This is Josette. I'll make that.
Is there a second?
It's Sarah Connolly. I'll second that.
Thank you, Sarah. All in favor?
Aye.
Any opposed? Any abstains? The motion will carry. Hearing the silence, we're going to go back to Dr. Lynch as Vice Chair, the nominee, one more time.
Respectfully declined, thank you.
Just checking to make sure you're still there for the whole call, Josh.
No problem.
I think that concludes everything on our agenda. Are there any other specific concerns or issues that anyone likes to bring up before we adjourn?
Could I just make just a general reminder, the EMS Memorial and, is next week in Albany. We always encourage agencies to attend if possible. It is Tuesday at, in Albany, and certainly on our website. And, we do have a local individual who's being placed on the wall, so.
Very good. I think that that's a great ceremony, and anybody who is out in the area to attend the memorial service, I think it's a great thing. I would also just like to reiterate again, on behalf of the REMAC, with EMS Week coming up, we certainly do appreciate not just everything all of our providers do, but the regional councils, the members of the REMAC, all of our providers, and our program agencies. Thank you for all that you do. And unless there is any last final comment, I think we will adjourn. Thank you very much, everyone.